immunomodulatory and anti-inflammatory activities. So for instance, you can show that the cytokines are upregulated that modulate behavior of different immune cells. In this particular case, heme oxygenase is upregulated. That's a potent anti-inflammatory effect. Also, there are other anti-inflammatory agents that are secreted in response to these cells. These cells enhance regulatory T cells, and they inhibit T cell proliferation. And this is a study we recently carried out with researchers, Dr. Wang at the University of Connecticut here, and that paper was published last year. And in this case, we're working with an experimental autoimmune encephalitis model, which is very closely mirrors multiple sclerosis. And what we found is that basically what happens in this model is that as multiple sclerosis develops, the animals become paralyzed. And so at 0, that's a completely normal animal that's moving around like a normal mouse. At 2, the animal's dragging its limbs, and by the time it's up to 4, it's completely paralyzed. And what we showed is that if you don't treat the animals are paralyzed. And here you see one of the animals that's untreated, which is staying there. By contrast, if you give it a single injection of our cells, the animal is moving around quite normally. And this table here shows you what happens. So here's a control animal. If you treat with the bone marrow-derived MSCs, you get a slight response. But again, the animals still remain paralyzed, like this animal there. And by contrast with our HMCs, you can see that the animals are not paralyzed. You can even irradiate these cells before you transplant them, and they still reverse or prevent the onset of this disease. If you look at what's going on histologically, you can see that the MSCs derived from the embryonic stem cells, but not the ones from the bone marrow, prevent demyelination in the central nervous system. So here you're seeing demyelination in these animals. And even with the bone marrow, here you can see in blue that there's still quite a bit of demyelination. But by contrast with the ES-derived MSCs, you can see quite a difference in the two groups. And we think one of the reasons for this is something known as extravasation. So if you use the bone marrow MSCs, what you're actually seeing is they get to the central nervous system, but they seem to get trapped here in the vessels. And the human cells are there stained in green, the GFP positive. And so they're not getting out of the vessels and into the tissue to repair it. By contrast, the ES-derived MSCs, you can see that they've extravasated, they've migrated out into the damaged tissue where they can exert their effects. And we've confirmed this by looking at a number of different proteins that are involved in extravasation. We've also looked at some other animal models. We looked at an experimental model of uveitis. Uveitis is an autoimmune inflammatory disease of the uvea, and it accounts for about 10% of blindness in the United States. And so we can, again, like we do with our patients, we can look into the eyes of these animals to get an idea of what's going on in real time. And so in a mild model, you can see this inflammatory infiltrate that occurs, and with the use of our MSCs that we derived from the embryonic stem cells, we were able to eliminate that. We repeated that with a severe model of uveitis, and again, what you're seeing here is a severe host infiltrate into the eye. By contrast, with an injection of our MSCs, you can see that process has been eliminated, and this is just a quantitation of that, and you can see the dramatic decrease in the number of lesions with the treatment of these MSCs. So these can be used for a wide range of autoimmune diseases. In humans, there are about 100 different autoimmune diseases. One that's an important one is lupus. You may know some people who have it. It's a systemic autoimmune disease that can affect virtually any organ in the body. At least 300,000 people, up to 1.5 million in the United States have this disease. There's no cure, and nothing has been approved for this for many, many years. And about 50% of lupus patients develop what's known as lupus nephritis, and you can actually see what is occurring. If you look at the kidney, the glomeruli, this is a healthy glomeruli, and then with lupus, you can see the deposition of these immune complexes, and that leads to kidney failure. And we can actually study that in this mouse model, this NZB mice. They spontaneously get this lupus. And in the untreated animals, you can see here in red, the animals start to die from kidney failure. quite precipitously, but a single injection of these MSCs or 2 injections of a smaller number here, you can see that it prevents the death of the animals. And more importantly, it actually is preventing the damage to the kidney. So when the kidney gets damaged, you start to see protein in the urine, and that's called proteinuria. So in the untreated animals, this is the degree of proteinuria, but in the animals that got 500,002 doses of these MSCs, you can see that it brought that down to a very, very low level. So very significant impact on the pathology of the kidneys. And you can look at BUN, creatinine and all, and you're seeing similar reductions as a result of these MSCs. And you may be thinking, oh, this is great, it works in mice, but will it work in humans? And there was recently a study that was carried out by Dr. Sun's group where they had 40 patients that were treated that had refractory lupus, and they were given MSCs that were derived from umbilical cord cells. And about 60% of those patients had a major or partial clinical response. In an earlier study, they actually also had a profound therapeutic effect, but long-term improvement in the disease activity, renal function, and antibody levels. So you would expect from a pluripotent stem cell source like this, where the cells have a stronger effect on a multitude of different immune modulatory parameters, that we would probably have even a greater impact. We also took a look to see whether or not these MSCs could affect pain. So this is an operant pain model, and what you actually have is the mouse has to push its nose through the snout to get the milk, and you can heat those bars up so that, as you elevate the temperature of the bars without any analgesic, you can see that the animal stops licking. So these little bars represent each time the mouse licks. By contrast, if you give the mouse analgesia to buffer the pain, you can see that the animal continues to lick. So it's a nice objective way to test for pain. So we looked at a couple of chemotherapeutic agents that cause, for instance, Taxol that causes neuropathy, or capsaicin, which can induce neurogenic inflammatory pain. And so in this model, what you're seeing here is in the untreated animals, you see that as time goes on, that they stop licking, because this is due to the pain. By contrast, when you give the animals the MSCs, you can see that there's no reduction in the number of licks. Similarly, if you do this study with the capsaicin, you can see without the treatment of the MSCs, the animals are experiencing pain and they stop licking. In contrast with the MSCs, you can see that they're not experiencing the pain. And we also just recently carried out a pilot study in animals that had severe Alzheimer's disease. And what we found is that these MSCs had dramatically reduced the deposition of beta amyloid in the cerebral cortex of these animals. So what you're seeing here, these are the plaques in untreated animals, by contrast to the animals that were treated with the MSCs. And these were treated systemically, not even intrathecally. And so this is quantitating. You can see a 50% reduction in the number of plaques. And similarly, there was a significant reduction in microgliosis. And so the next stage is to see whether or not we can actually impact memory and cognitive function. And so again, I alluded to some of the differences that we're seeing in these cells. So if you compare the ES-derived MSCs to the bone marrow and cord blood, you see that they have the lowest expression of this pro-inflammatory interleukin-6, which is very important, for instance, in diseases like multiple sclerosis. They also have higher expression of extracellular matrix degrading enzymes, which are important for them to get to where they need to get in the damaged tissue. And if you want to look at how fast they can migrate, you can actually peel some of the cells away and watch whether the cells can migrate. So here's time 0 in the 6 hours. You can see the cells are migrating into that area. By contrast, the MSCs that were derived from umbilical cord or bone marrow, you can see that they're not migrating very much at all. So we think this is really a combination of lower inflammatory cytokine expression and better migratory capacity through the extracellular matrix. And just to mention that there are also a lot of other potential pluripotent stem cell therapies. This is just one example. We've derived these hemangioblasts that can be used for vascular repair. So we can label, these are bipotential cells that can become either immune cells or endothelial cells for vasculature. And if you label them with GFP, you can actually show within 24 to 48 hours, they actually go to the injured vasculature. In this case, it was ischemic ischemia reperfusion injury to the retinal vasculature. You exert pressure, and you can see that in the untreated eyes that there's no incorporation of these cells. So they're smart and they know where to go to home to the damaged tissue. Similarly, we carried out studies in animals that had ischemic limbs. So if you look at the Doppler at the hind portion of the mice, this is the tail and this is the blood flow to the limbs. You can see this limb had ischemia to one of the limbs, one injection of the labeled angioblast, and you can see within a month, complete restoration of the blood flow. Similarly, in an animal with a severe myocardial infarct, you can see that we were able to cut the mortality rate in half. This is the sham versus the angioblast. And this is just showing you that these cells, again, can turn into, vasculature. This is a capillary structure. The cells take up LDL, and they also turn into a variety of other hematopoietic cell types. So, for instance, we can turn them into entire tubes of red blood cells that transport oxygen, just like normal transfusible blood. We can also get the cells to a nucleate, which is very important. And we've recently generated an IPS line from an O negative individual, so that the blood that we generate is now universal blood, so that means that we could transfuse that blood into virtually everyone in this room, so we wouldn't need to type the blood. And also, as you know, there's a serious shortage of platelets, due to trauma if you get in an accident. And this is an ideal early candidate for clinical translation because platelets don't have any nucleus, so you don't have to worry about tumorigenicity. And one of the problems right now is that these, when you generate platelets, they only survive for a few days, say 5 days. So that's why there's a shortage, because the cells cannot be preserved. What we're able to do is to turn our, whether it's iPS cells or embryonic cells, stem cells, into these what's called megakaryocytes. These are the giant multinucleated cells that then send out these pro-platelet structures here that then cleave off to become the platelets. And we find that these platelets that were generated, we can generate these in very, very large numbers, actually can form clots very nicely. They also incorporate into a mouse thrombus that was due to damage to the arterial injuries with a laser. And if you look at the ultrastructure of these platelets, say for instance a platelet here that was generated from iPS cell versus a normal platelet, you can see that they're virtually identical. They have this dense tubular system, these alpha granules, and all the various other micro organelles, the mitochondria, for example. So the hope is that platelets will also be able to translate it pretty soon into the clinic. And so this is just the tip of the iceberg, and so as you can see, there are a lot of different pluripotent stem cell therapies that we hope are going to be moving into the clinic in the coming years. And finally, I just want to thank the people who did all the work. Of course, there's a team at ACT. In particular, I'd like to thank Shujang Liu and Aaron Kimbrell, and then of course I'd like to very much thank all our academic collaborators at UConn, at UCLA, Harvard, and Tufts. Thank you. Yes.
Well, it's wonderful, Bob, to hear the progress towards the clinic. But you mentioned that the eye is an immune site, and you don't have to worry about